back to Veronica and Shannon Know Everything. I know we've been gone for a while, but we're back. Today we're going over the bones, but before we jump into that, we need to just kind of clear up a few things. The haters are still out there, and we're above them still. They're still present, so, we're living our best life. Also, disclaimer, we had a real MD, Vadim, come in, so this information is legit, okay? Not a PA, MD, he verified this information, so you can trust it, okay? So now we're going to jump into a photo here, drawn by the lovely Shannon, great artwork. So we have the hip, we have our femur. So just to begin, we want to kind of go over some details specifically that we find that are going to be important when it comes to the exam. So we have Shenton's line. You can kind of see that it just follows the femur and kind of goes into the hip, and this should be equal bilaterally. We then have the neck shaft angle. So normally it should be between 120 and 130 degrees. You can find that it's going to be smaller or larger. So with the acute one, you're going to find that it's called a coxa vara, so very small. If it's obtuse or large, it's going to be a coxa valga. We also have Klein's line. So this should start at the operator and go through the head, and this is related to skiffy. So if it's abnormal, you're going to find that it does not go through the head, so it's going to kind of be like that. Now we're going to go ahead and jump into all of our diagnoses. So to begin with, we have the posterior hip dislocation. So with this, you're going to find that the patient has an internally rotated hip. It's going to be adducted, so adduction, and it's going to be shortening, so you're going to find that they are like this. The most common cause on a PA perspective is a motor vehicle accident, and it's going to be native. So now as far as treatment, what you're going to do is reduction. You want to do this within 6 hours, otherwise you're going to have a risk of ABN. And then you're also going to have some restrictions with non-weight bearing. Again, PA perspective, the non-weight bearing. And then you're going to admit them. As far as
you're so mean.
You can have a sciatic nerve injury, and yeah. So now we're going to go ahead and move down to the anterior hip dislocation. So it's kind of the opposite. So you're going to find that the hip is externally rotated and a abduction, so away. Again, treatment is going to kind of reduce it. You want to do a CT before and after. Just after. X-ray before. As far as any complications, so they could have femoral nerve injury, they could have vascular problems. And now we're going to go ahead and move down to a femoral neck fracture. So as far as signs and symptoms, we can't really show you the x-rays, but you're going to kind of identify this by looking at those images. One thing to know is that you can have ABN within 48 hours, probably around 40%. So you can find that there's a big difference between these dislocations. As far as treatment, we're going to be doing immobilizing, pain meds, and then do a surgery consult. And now we're going to move, this is also known as an intracapsular. You're going to find that the opposite is an extracapsular. Again, we can't really show you what this looks like. You're just going to have to look at those images and be able to identify that. Treatment, same thing, immobilize, pain meds, and then ORIF. As far as any complications, the patient can become hypovolemic. You can get clots, and then there's a low risk with ABN, so you don't need to worry too much about that. Now with skiffy, this is where the femoral head kind of slips off the shaft, and these are your fat kids. So remember that kids like Skippy peanut butter, kind of like Skippy. And this is going to relate back to that Klein's line that we talked about back here. So that's kind of going to be helpful with diagnosis. And then as far as treatment, you're going to have a surgical fixation bilaterally. Sometimes just kind of depends on the patient. Now moving down to Purdy's. So this is going to be a crumbled femoral head, and again, you're going to see this on x-ray, and you're going to find that this is going to be a temporary loss of blood supply, so it's going to be like ABN in children. Early diagnosis is the best way to go about this, so if you can do that, great. You're going to brace it, and then you're going to refer it to a self-limiting disease. So now moving down to septic arthritis. So labs are going to be important in this case. You have a patient who, or the mom or dad brings in the patient, and they're going to be saying that their child is not walking for whatever reason. So, or example, like a 4-year-old is just not walking when they were previously. You're going to do some labs, and then a big thing is going to be the CRP. It's going to be greater than 20. That's going to be a strong indication for this. And then another thing that's associated is if the patient comes in, same deal, they don't want to walk, ED labs are totally normal, like no fever, no increased white blood count, you're going to be thinking of a transient synovitis. Look at the history because this is associated to a prior virus, so like an upper URI or something like that. So again, we went over the hip today. This is all great material, confirmed by an MD, so we are good to go. Thanks, guys.